This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, a senior attending in neurosurgical oncology.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from the Journal of Neuro-Oncology titled Gamma Knife Radiosurgery for Renal Cell Carcinoma Brain Metastases Across Systemic Therapy Eras, Survival, Intracranial Failure, and Lesion-Level Predictors.
This is a timely topic, Alara. For a long time, the dogma in our field was that renal cell carcinoma, or RCC, was essentially radioresistant. When I was a resident, if a patient had RCC brain mets, the prognosis was grim, and we weren't always sure how much of a dent Gamma Knife could really make.
Exactly. And that's what makes this paper so interesting. It's a large-scale, retrospective look at how outcomes for these patients have shifted as systemic therapies have evolved. The researchers divided the patients into 3 distinct eras based on the primary systemic treatment available at the time.
Right. Let's set the stage for our listeners. We have the cytokine era, think interferon and interleukin, which was the standard pre-2006. Then we have the targeted therapy era, dominated by VEGF inhibitors and TKIs like sunitinib. And finally, the modern immune checkpoint inhibitor, or ICI era.
The study cohort is quite impressive. They looked at 264 patients who underwent Gamma Knife radiosurgery for a total of, get this, 1,655 individual lesions. That's a lot of planning sessions.
It really highlights the shift toward using SRS for multiple metastases. But let's jump into the big question, survival. Did the systemic therapy era actually change how long these patients lived after their first Gamma Knife treatment?
It did, and the difference is stark. In the cytokine era, median overall survival was only 4.2 months. In the targeted therapy era, it jumped to 11.3 months. But in the modern ICI era, median overall survival reached 17.5 months.
17.5 months. That's a 4-fold increase from the early days. As a surgeon, that changes the way I counsel patients in the clinic. If I know a patient is on a modern ICI regimen, I'm much more aggressive with local control because they actually have the systemic longevity to benefit from it.
And the study used a Cox proportional hazards model to confirm that the ICI era was a significant independent predictor of improved survival, even when adjusting for things like the Karnofsky performance status and the number of metastases.
Now, let's talk about the lesion-level predictors. This is where the neurosurgical nuance comes in. We've always debated the optimal dose for RCC because of that perceived radioresistance. What did the study find regarding local failure?
This was one of the deeper dives in the paper. They looked at what caused a specific lesion to regrow. Interestingly, the cumulative incidence of local failure at 12 months was about 11%. But when they looked at predictors, the 2 big factors were lesion volume and the marginal dose.
I'm assuming larger volumes fared worse.
Correct. Larger lesion volume was significantly associated with an increased risk of local failure. Specifically, for every 1 cubic centimeter increase in volume, the risk of failure went up. But more importantly for our planning, the marginal dose was a key player.
Did they find a sweet spot for the dose?
They did. The paper suggests that a marginal dose of 20 gray or higher was associated with significantly better local control. When the dose was below 20 gray, the local failure rate climbed.
That's a critical point for the residents listening. When you're contouring an RCC met, if the volume and the proximity to eloquent structures allow it, you really want to push for that 20 gray margin. Shying away because you're worried about radiation necrosis might actually be doing the patient a disservice if it leads to local recurrence of a radioresistant tumor.
Speaking of radiation necrosis, the study did track it. The 12-month rate of symptomatic radiation necrosis was around 5%. They didn't find a massive spike in necrosis in the ICI era, which has been a concern in some smaller studies. The idea that immunotherapy might synergize with radiation to increase inflammation.
That's a reassuring finding. It suggests that while ICIs are improving survival, they aren't necessarily making the brain more vulnerable to the Gamma Knife itself, at least not at a level that should deter us from standard dosing.
What about distant intracranial failure, or DIF? For those who don't know, that's when new metastases pop up in the brain outside the original Gamma Knife field.
That's always the Achilles heel of SRS, isn't it? We fix the 3 lesions we see, and 3 months later, there are 4 new ones.
Exactly. The study found that the 12-month cumulative incidence of DIF was about 45%. Interestingly, the systemic therapy era didn't have as much of an impact on preventing new lesions as it did on overall survival.
That's a subtle but important distinction. The immunotherapy is keeping the patient alive longer, but it's not necessarily creating a shield that prevents new brain mets from forming.
Right. In fact, because these patients are living longer, that actually have more time to develop new metastases, the paper noted that patients in the ICI era were more likely to undergo salvage treatments, either more gamma knife or surgery, because they were still systemically stable.
It's a shift in the treatment paradigm. We're moving toward managing brain metastases as a chronic disease. We use gamma knife to mop up new spots as they appear, knowing the ICI is holding the rest of the body in check.
There was also a mention of the GPA, the Graded Prognostic Assessment. For RCC, we usually look at the DS-GPA. Did the study find it still holds up?
They found that the DS-GPA was still a valid tool for predicting survival, but they argued that the era of systemic therapy should perhaps be integrated into these models. If a patient has a poor GPA but is starting a dual-agent ICI regimen, their actual prognosis might be much better than the old scores suggest.
To summarize the lesion-level data for the listeners, they analyzed over 1,600 lesions. The median volume was quite small, about 0.2 cc, but the range was wide. The fact that they could show a dose-response relationship with 20 gray as a threshold in such a large dataset is quite robust.
It's also worth noting the limitations. This is a retrospective study. We have selection bias here. Patients who were healthy enough to receive ICIs might have been healthier to begin with.
True, but the researchers did a good job of using multivariable analyses to try and isolate the effect of the therapy era itself.
So, Ella, if you're a resident and you're looking at an RCC patient with a 1.5 centimeter cerebellar met, what are your takeaways from this paper?
First, I'm looking at their systemic status. If they're in that modern era on ICIs, I'm optimistic about their survival. Second, I'm aiming for a marginal dose of at least 20 gray if I can safely deliver it, because I know that's the threshold for local control. And third, I'm telling the patient that while we have a high chance of controlling this lesion, there's a nearly 50% chance we'll see new spots within a year, so we need to stay vigilant with our follow-up MRIs.
Spot on. It really dispels the myth of RCC as a tumor where radiation doesn't work. It works, but you need the right dose and the right systemic environment.
It's an exciting time in neuro-oncology. We're seeing the survival curves finally move in the right direction.
Definitely. Well, that's all the time we have for today. A big thank you to the authors of this study for providing some much-needed clarity on the gamma knife management of RCC.
Thanks for listening to the Neurosurgery Hub podcast. We'll link the full study in the show notes. I'm Dr. Alara.
And I'm Dr. Eris. We'll see you in the next episode.